Good evening, everyone. Thank you so much for being here for today's program. I think by mistake I said good evening. I should be calling it as a great evening because we have a great doctors here with us. We have a great panelists with us, Dr. Shaila Sheikh, Dr. Bini, and Dr. Bharti said with us, and I'm sure their expertise on the different set of questions on the PCOS and GDM will definitely give uh, hands-on learning for each one of you who's attending this program. So I'm not going to take much time, and I'm handing over it to Shariva now. Shariva, Dr. Shariva, please requesting you to continue.
Good evening, everyone. Hi, I'm Dr. Shariva Randive from the Scientific Services Team, Team USV. I welcome all of you all on the behalf of Team USV. A warm welcome to everyone and to our three speakers, Shaila ma'am, Shaila Sheikh ma'am, Bharti Sheikh ma'am, and to Dr. Bini ma'am. Going forward first with our presentation as we know that the growth of a particular nation is based on the health of the nation, and the health of the nation lies in the health of the youth and health of the woman. Coming forward further, so for this reason we have our three lady speakers, women empowerment, basically three lady speakers, the triple power on the podium. We welcome our three speakers. Ma'am, thank you for your time and thank you for being there. So we have a leading gynecologist, Dr. Bharti Seth, ma'am, and we have Dr. Shaila Sheikh, ma'am, who's a leading endocrinologist, and we have Dr. Bini, ma'am, who's a leading dermatologist. So before yeah, so before we start up with the presentation, I would just want to give a small backdrop about our today's topic. I warmly welcome all of y'all for the PCOD and for gestational diabetes mellitus talk. So we believe in this concept of do not leave the pregnant GDM woman alone. So based on this concept, speaking about today's crosstalk, which is based on PCOD and GDM, both of them are interrelated conditions which far each other. Health implications to for a woman, especially in India, where the prevalence is alarmingly high. Up to 35% of women of reproductive age in India are affected by PCOD, while GDM prevalence is around 10 to 12% in rural and in urban area, respectively. Going further, the dual burden of PCOD and GDM has profound consequences, including higher risks of pregnancy complications, long term diabetes, cardiovascular disease for mothers, and metabolic disorders in offsprings. In a country like India, where genetic predisposition and lifestyle factors worsen these conditions, early detection, holistic management, and awareness are critical to improving maternal and fetal outcome. This crosstalk brings together a multidisciplinary panel of experts to discuss the various dimensions of PCOS and GDM, from hormonal and reproductive health to dermal and emotional well-being. The goal of this crosstalk is to shed light on early detection, management, and holistic care approaches that can help women lead healthier lives while managing PCOS effectively. Going further, I would want to give a formal introduction of our triple woman power for this evening, starting with Dr. Bharti Seth, ma'am. So, madam is a leading gynecologist. She's a director at Bharti Nursing Home, Dwarka, been a president of IMA Dwarka, co-chairperson on the Gynac platform of IMA Dwarka. He's a visiting consultant to several tertiary care hospitals. At the same time, she is a part of the alumni of SMS Medical College, Jaipur. She has lifetime membership of leading medical organizations like IMA and Foxy. Thank you, ma'am. Thank you for being there with all of us. Going further to Dr. Shaila Sheikh, ma'am. She's a leading endocrinologist and a consultant endocrinologist at Cefi and Reliance Hospital, Mumbai. She's a principal investigator and international clinical trials, around 35 clinical trials. She's a member of executive committee of ESIC, treasurer of ESIC Maharashtra year 2019-2022, a member of scientific committee, and has been awarded by as top doctors in Mumbai by Times of India year 2017-2023. At the same time, it's a proud moment for us to say that ma'am is an author of International Hajj and Diabetic Guidance. So it's a privilege to have ma'am on on this podium. She has published several peer-reviewed in peer-reviewed publications, papers, review articles in international and national journals. Along with that, she's been a speaker on national and international forums. Thank you, ma'am, for being there and cutting out time for us. Going further to Dr. Bini ma'am, who's a leading dermatologist. She's a working consultant at Suhana Hospital, Mumbai. She has a research experience in borderline tuberculoid has Hansen's disease and has received several national awards at Cuticon, Maharashtra. At the same time, she has published papers in renowned national and international journals. She has received scholarships for oral free paper communication in Dermacon year 2018. She has several oral and poster presentations at national conferences. She is skilled in conducting several procedures. Rather, I would say her area of specialities in several procedures, like which are involving laser procedures, Botox fillers, phototherapy, and radio frequency. So, thank you all of y'all for your presence today and for cutting out time for us. So now, I think we should be starting with our crosstalk session for today. Going further, it's my privilege to that I get a chance to ask such higher hierarchy authorities questions and get valuable insights on this particular platform, whereby all of us can have get authentic learning inputs, which would probably help us in in probably help us in grow for the educative growth of our nation. So my first question, as we start with the question round, is to Dr. Bharti Sheth, ma'am. So, ma'am, my first question is to you. Could you explain what PCOS is and share your insights on its prevalence in India? Why is it such an important health issue? Ma'am, am I audible? Hello? Hello?
I'm audible?
Yeah, you're
I
audible. Yes, ma'am, you're
I didn't
audible.
unmute. I did.
Yeah.
Sorry.
So, ma'am,
So,
do you want me to repeat the
no,
question?
no. I heard your question. I
Okay,
got your question.
yes,
See,
ma'am.
polycystic ovarian disease, this is an hormonal imbalance in mainly of the reproductive age group,
Okay, yeah,
where the irregular menstrual cycles, hyperandrogenism, and the enlarged size of ovaries, that polycystic ovaries, they are characteristics of this polycystic ovarian disease. This is mainly a problem. It starts with the menarche and till menopause, mainly of the reproductive age group, where cause of this reason of this polycystic ovarian is not that is not known much, but some genetic predisposition is there, and then the faulty lifestyle and the poor dietary habits, like nowadays people are very much fond of having junks and all those kind of things, that probably plays a role into it. Stress and poor lifestyle, that is the predisposing factors. Nowadays we see so many girls, they are coming in our OPD with the these kind of problems, like they are having irregular menstrual cycles, and then they are obese also. They have weight gain is the basic problem, like obesity and this PCOS, that goes that is a vicious cycle. Once patient is PCOS, polycystic ovarian disease, she will gain weight, and once she will gain weight, she will again what that hormonal imbalance will worsen with that. So obesity is also one of the reason that nowadays so many girls, and almost I think two or three patients in our OPD out of 10, like almost 30% population is getting this kind of problems nowadays, and this is a very important thing to diagnose it timely, Because this is not only related to your poor this irregular menstrual cycle, but it is related to your fertility also. So reproductive health is not good, but then it is having far long impact on the metabolic syndrome also. Like patient is prone to have type 2 diabetes mellitus, hypertension, and then in the later stage, like in the menopausal age, they are prone to have the endometrial cancer also. So PCOS patient, they are it is very important to diagnose them timely, uh, I mean counsel them timely, and then treating them timely. So it is not only the fertility problem that they will have infertility, but otherwise also their physical health is at stake. Along with this physical health, their mental health is also at stake, just because they are having obesity, so they will have body shaming sort of thing. They are
Okay.
under stress because they are not having regular periods. Then if they are infertile, not having children, then also they are stressed out. So it's a double edged sword. Like
Okay.
patient is PCOS, then his her mental as well as physical health, both are at stake. So we really need to take care of this thing, that we should timely diagnose this thing. And problem is, like, this is an underdiagnosed thing in the rural areas, because their awareness is not there. Mother will say कोई बात नहीं, 2 महीने पीरियड नहीं आता बच्चे तो कोई दिक्कत नहीं है, तुझे ये हो रहा है तो कोई दिक्कत नहीं है. And then in the urban areas, this is over diagnosed things, because here every patient who is going for the ultrasound scan, they will write down that she is PCOS. And then nowadays patient comes in our OPD and they says, ma'am, मैं PCOS हूँ, PCOS. So initially I was not getting it, what PCOS is. Then I came to know that they are saying PCOS. So it's a height of this thing ki they are overdiagnosed. The problem is again underdiagnosis and overdiagnosis. So we really need to diagnose it correctly for the patient and then treat them correctly. So it's a really major health issue. Yes.
Yes, yes, ma'am. Yes, ma'am. So, thank you for your explanation, ma'am. Coming to our next question is my next question is to Dr. Shaila Sheikh, ma'am. How does insulin resistance and hyperandrogenism contribute to the pathophysiology of PCOS, and what are the effective pharmacological interventions you would like to suggest?
To be very honest, before I go to your question,
Yes, ma'am.
just one part which I want to address. I totally agree with Dr. Seth, that
Yeah,
we are facing this problem increasingly. And since we have this platform with a number of people who have logged in, I think it's very important that we understand that there's no specific diagnostic test that unequivocally tells you that you have PCOS.
yeah,
Least
yeah.
you need 2 out of 3 factors. If we get this right, I think what ma'am is saying, neither will we underdiagnose nor will we overdiagnose our patients actually. And when you look at these 2 out of 3 criteria, as we all know, it's very, very important along with this when you're diagnosing PCOS to rule out hypothyroidism, to rule out hyperprolactinemia, to rule out non-classical CH. And when you're talking about these features, where you're talking about 3 basic features, you're talking about hyperandrogenism, which is one of the features. You're talking about ovulatory dysfunction, which can be either anovulation or any other kind of the ovulatory dysfunction. And of course, PCOS on ultrasound, which also requires a ovarian volume more than 10 cc and at least more than 20 follicles at the periphery. I think if we keep this in mind, that you need 2 out of these 3 criteria, and it can be any 2. For example, there can be the one phenotype would be the androgen excess, or it could be the ovulatory dysfunction phenotype, or the PCOS. And then you can't really go wrong as far as diagnosing PCOS is concerned, and that's where half the job would be done, to be very honest. Coming to your pertinent
Yes, ma'am.
question,
Yes, ma'am.
you are asking me, Dr. Shariva,
Yes, ma'am.
where does insulin resistance play a role in the entire pathophysiology of PCOS? Insulin resistance, mind you, is present in almost 80 to 85% of people with PCOS. That, I mean, when I'm talking about obese PCOS, you will
Yes,
be
ma'am.
surprised that even in lean PCOS, almost 20 to 25% would have some degree of insulin resistance. Ma'am very rightly alluded to lifestyle genetics when she said that this all contributes to the pathophysiology. The issue with insulin resistance is that insulin resistance is going to transfer into all kinds of metabolic abnormalities, and the patient with PCOS, that's why we say practically is going to have metabolic issues which are going to span a lifespan, including the post-menopausal period. we all know some of the symptoms which worry our patients most is the hirsutism, the acne, the loss of hair, the weight, the irregular menstrual cycles, mood disturbances. And it is very important when you are assessing your patients to be having a much more holistic approach to your patients. And that's when you're talking about holistic approach. I think this is one area of medicine where actually multidisciplinary care is required, be it our gynec friends, be it our dermat friends. We always look after our PCOS patients as together, because this is one area where multidisciplinary care becomes very, very important and everybody needs to be involved. Coming in short to the pharmacological intervention, Shariva, what we
Yes.
are routinely doing in clinical practice is definitely we use combined oral contraceptives now. We have low dose progesterone with estradiol, with ethinyl estradiol available very, very easily. Progesterone which have lesser side effects, because we need to be able to reduce the LH levels, we need to increase the SHBG levels. Metformin is a very good medication to be using, especially in our obese adolescent PCOS, because it does give you a lot of advantages. And of course, then depending upon what kind of manifestation, for example, if the patient is having significant hirsutism, we do add spironolactone for our patients. What
Okay.
is very, very fascinating is that now newer medications like GLP-1 receptor agonists are really have really shown us some fantastic data regarding the improvement as far as insulin sensitivity is concerned, helps in weight loss, and actually potentially is going to be the next treatment for PCOS. Along with this, Shariva, you can't afford to forget lifestyle.
Yeah.
Lifestyle remains one of the cornerstones of treatment, and it requires actually therapy, Shariva, is all dependent at what point of time the patient comes to you. For example, if you're seeing a patient in adolescence, your therapy is going to be different. When a patient requires fertility, your treatment is going to be different. When a patient comes to you in perimenopause or menopause, the patient is going to be different. So, and on the background of PCOS, depending on what your patient's your patient, what symptomatology your patient is having, what your patient's requirements at that point of time, that's how therapy would be sort of tailored for your patient. Thank you very
So
much.
basically, you're saying it will be individualized according to an individual patient. That's what you're saying. Thank you, ma'am. Thank you. Coming forward to the next question, my next question is for Dr. Bini, ma'am. So, as you know, the youth and the rising acne issues, the young girls coming with acne issues, skin issues. So, just this is a question on their behalf. This is a question from the youth of the nation today. So, acne and skin disease issues are also very common issues in PCOS. So, what are the most effective treatments for hirsutism? Which in layman terms we say we call it as excessive hair and
Unwanted
acne.
body hairs,
Yeah,
right?
excessive unwanted body hair and acne in PCOS, and how do they work at the hormonal levels?
Actually, I think Shaila ma'am and the Bharti ma'am already explained very well. It is a metabolic dysfunction, endocrinologic disorder, reproductive disorder. So normally patient to come with excessive unwanted body hair. It can come on the face, chest, back, on the pubic area. So then I ask the patient, do you have any menstrual irregularity and anything else like that? Because I don't interfere, I don't intervene the treatment in the, like, I always counsel the patient, go to certified endocrinologist or the gynecologist, first rule out PCOD. I am not the best person who can diagnose, as either it will go underdiagnosed, a patient will go into underdiagnosed or the overdiagnosed. So first I consult the patient regarding PCOD and how to manage by endocrinologist and the certified gynecologist to go there. Now talk about hirsutism, then I consult the patient, whatever the hair has come out, I will take care about those things. It will go laser hair removal, because whatever the hair has come, it won't go with any medicine.
Right.
But then I see the patient's hair. Is it pigmented hair, like more black in color? How's the texture? Then I talk about laser hair reduction. then I normally, it is very hirsutism is very distressing implication of PCOS because it lower the self-esteem, and it also it is very common. We see in at least 50 to 70% of the women with PCOS, and along with that, I start the patient on the anti-androgenetic medications like finasteride and the spironolactone, right? And that will help. But whatever the hair has come out, it will go with the laser hair reduction. And then I consult the whatever the sittings and all. It is very different. The patient with PCOD and patient without PCOS. Then I tell the patient, go to certified gynecology or endocrinologist and diagnose yourself. Okay. And now coming to acne. So first, I see what I see. Acne is very like common in the patient who has already hirsutism. And then along with that, acne is very common rather than acne alone. So then I treat the patient with the uh, tetracycline with the oral retinoids. Along with that, anti-androgenetic medications like finasteride and spironolactone, because I give OCPs only if patient is not ready to go to certified endocrinologist or the or the gynecologist. Then I will start. Otherwise, OCP who can uh, handle these things, like I think they are the best who can handle PCOD very well. I treat only the complications. I don't put the patient on the unnecessary OCPs and other medications.
But ma'am, just one thing I wanted to ask you is that do you think that that laser therapy has actually got a lot of change through cosmetic point of view for women, like
Yes,
who
yes.
have this body shaming issues because of the acne
Yeah, patient
and
has
excessive hair?
they have very, I think patient who has the hirsutism, they have very low self-esteem. So
Yeah.
patient, they don't even go to attend the any parties, any social gathering. They always tell me first मैं क्या करूं, मुझे रेजर करनी पड़ती है, हर एक तीसरे दिन रेजर करनी पड़ती है. So then why, what is the root cause of this? I have to, then I tell the patient, I want to find out what is the root cause of the hirsutism, because it is not common in every patient, right? Every
Yeah.
female. So first diagnose yourself and treat yourself for the PCOD. Along with that, I will take care about excessive unwanted hair.
Okay. So it's more of counseling and the cosmetic
Yes.
therapy as what you go.
Just tell one very interesting incident
Yes.
for this dermatologist, ma'am. One of my patients, she was PCOD. She had hirsutism and acne and all those things. And drospirenone nowadays, that is a very good, progesterone which can help out reducing these acnes. So I started my patient with that drospirenone, and then her face was all clear. She was very happy with the 2-3 cycles. She was all okay. She was very happy. Then one day she came to, she said, my brother is also having those kind of acne. So, ma'am, I started with that medicine with my brother also. I said, my God, not for your brother.
So,
This also
Sharma,
happened.
I want to ask just ask one question. So, how to start finasteride? A patient have complain of irregular periods. How to start finasteride? It should given like in normal patient without PCOS. So, Bharti ma'am, how to start? Normally, I give if the patient came to me with female androgenetic alopecia without PCOS, I start the patient 5 mg per 5 mg finasteride. So
I
it
don't
is
have
okay to
any.
start.
No, I don't have any, experience with finasteride because we are just giving just drospirenone for all those things and spironolactone. That is what we are giving,
So,
not giving that.
Shalanam, what is your point of view? We should start the patient on finasteride or not? Or we should start from lower dose?
Yeah. Yes, ma'am.
Sorry.
Yeah.
Finasteride, ma'am, I don't use at
You
all.
are- I have no experience with
I
finasteride.
don't use finasteride. We generally use spironolactone. That's what we are very, very
That is
comfortable
what
with.
we
The only issue with spironolactone can be intermenstrual bleeding, and that's the reason we will prefer using spironolactone with, a combination of OCPs and spironolactone.
and
So,
Hispanic or cyproterone also we are using for that purpose.
yeah,
Cyproterone with the estrogen we are
spironolactone is
using.
available in the combination with an OCP.
Yeah.
So we are using that.
Yes. Yes. That we are using actually.
And along with that, ma'am, we just add spironolactone. But I have my personal experience with finasteride is very, very limited. I don't tend to use it.
Okay.
So, thank you, ma'am, for your valuable inputs. Coming forward next, my next question is for Shaila Sheikh, ma'am. So, ma'am, what role does OC pills, OC pills, you can say, like contraceptive pills, play in managing hormonal imbalance in PCOS patients, particularly in terms of menstrual regulation and reducing androgen levels?
Sharifa, OCPs basically play a very important role. They have this very big bad name. The moment you say OCPs to a patient,
Yeah.
it's like the mother is like, oh my God, why are we giving OCPs to the patient? But
Right.
actually, have a central role in managing PCOS because two of the main pathophysiology of PCOS, for example, where they increase the SHBG levels, they're going to influence your insulin levels. The main pathophysiology, which is alteration of your LH FSH ratio, is addressed to a significant extent by the OCP. And maybe an adolescent, a young lady, when she starts getting her periods regularly, there is some amount of predictable shedding of the endometrial lining. It is actually psychologically also very, very, de-stressing for the patient, because we all know as a result of anovulation, the cycles are absolutely irregular. You may have cycles which are, the bleeding may be irregular. And all these finally are going to, affect the inpatient's quality of life, the patient's mental health. So the basic pathophysiology is also addressed. Along with that, to some extent, the symptomatology is also addressed. So I personally think that OCPs are it's like a central fulcrum when you manage your patients with PCOS along with everything else. They regulate cycles, they help as far as your increase of SHBG is concerned, so they reduce, and also they reduce your LH levels. So along with the background therapy, I think OCP should be the first line treatment as far as hormonal management is concerned. Because when they reduce androgen levels, they're also going to improve the acne, they're also going to reduce the hirsutism. So 6 months of OCPs are the first line of therapy, even when the patient comes to you with hyperandrogenic PCOS, not only with ovulatory dysfunction, even when it is because of reduction of androgen levels because the SHBG levels are going to increase. That makes a very, very big difference as far as therapy is concerned.
Okay, okay. Thank you, ma'am. Thank you. So, coming next, so this question is again for Dr. Bini, ma'am. As you know, cosmetically, there are other changes also which tend to happen in women, and the most common changes are hair loss. So, rising issue of hair loss, which we commonly call it as alopecia. So, how should the dermatologist address androgenic alopecia in PCOS, and what are the current therapeutic options available?
So now first, it is very common in the PCOD patients, like due to the excessive production of the testosterone. So I treat the patient with anti-androgenetic medications like spironolactone, which reduces the miniaturization of the hair follicles. Like along with that, I also start the patients on the another supportive therapy like the minoxidil 2%, like twice a day. And newer therapies has come which doesn't affect your hormonal level. And if a patient doesn't want, I don't want to start the patient on the finasteride and all, then I start the other therapies like PRP, that platelet rich plasma, growth factor concentration, and the mesotherapy, advanced exosome. There are so many things which can reduce the miniaturization of the hair follicles, which will help in this androgenetic alopecia. So I to start the first is the anti-androgenetic medications along with minoxidil. Then if patient is ready to go for another procedures like PRP, then I start the patients on these therapies also.
Okay, okay.
Yes.
Thank you, ma'am. Thank you for this answer. This particular question was from the young girls, basically. So they face all these acne issues and hair loss. So thank you for answering these queries. The next question is to Dr. Bharati Seth, ma'am. So, ma'am, how can ovulation induction therapy improve fertility outcomes in women with PCOS, and what are the preferred first-line treatments?
The fertility, this ovulation induction that improves the fertility in the PCOS patients is because PCOS is actually a problem in ovulation because of insulin resistance and because of hyperandrogenism. Ovulation is not there, so patient is having all that hormonal imbalance and LH levels are high and all those problems are there. So patient is not getting the regular periods because she's not having the ovulation, not getting the regular periods. So they are infertile. Also, that is the basic problem. So actually, basically, we need to correct their hormonal imbalance. What Shaila madam said, ki COCs, oral contraceptive pills, they are very
Yeah.
important. Once patient comes to us, PCOS wala patient, I ask them to take the COCs. Like then
Yeah.
patient bounce backs to you. They say we are coming for the मतलब बच्चा पैदा करने के लिए आए थे, and then you are giving us the COCs. But they just don't understand that COCs, they are very important to correct the hormonal imbalance. Because COCs, they will reduce the androgen levels, they will improve the insulin resistance. So then we give the ovulation inducing agents, then they are more helpful. If we have corrected the hormonal imbalance, and then we if we are giving the ovulation inducing medicines, then they are the more beneficial. So earlier we were used to giving this clomiphene citrate for that, but then clomiphene citrates they are the multifollicular that kind of yield is there. But we want monofollicular, means we want only one or two eggs for the natural conception, not the multiple eggs. With
Multiple.
clomiphene citrate, that is the problem, that multiple eggs will grow. Patient may have the multiple pregnancies. And then with clomiphene citrate, one more problem is there, that they are hyper responder. With the PCOS patients, they are hyper responder, means their hormonal milieu is like that. If we are giving the ovulation inducing medicines, they will have multiple eggs, and then that creates another problem with them. So nowadays letrozole is there, that is the first line treatment. With that they are this letrozole is giving this is aromatase inhibitor, and increases the FSH levels, and gives the monofollicular yield to us. Along with that, actually insulin sensitizers, if they are being given, like myoinositol and dechiroinositol plus metformin, that is really helpful for the ovulation induction. Lifestyle modification is the key factor for that thing, because they say is key. If you can this weight reduction, along with that lifestyle modification, weight reduction is the key factor for that. If we say ki if 5 to 10% of the existing weight, if patient is able to reduce, that will correct their this thing menstrual cycle also, and helps in the ovulation also. So lifestyle modification, insulin sensitizers along with letrozole, that is the first line treatment for the ovulation induction in the patients.
So, because ma'am, this concept was very important, as what you said. People have this concept that we want to conceive. Then why are they giving us OC pills?
Yes,
So
yes,
that conceptual clarity is really, really very, very important, I feel.
yes,
And
that is
this is
very
a
important. For 2 or 3 cycles of the being given the COCs, that improves your results with the ovulation induction
yeah.
medicines.
So this probably clears the concepts of the potential mothers. You can say that.
Yes.
So coming back again to Dr. Bharati Seth, ma'am, ma'am, I wanted to ask you one more question: is how does PCOS affect pregnancy outcome, and what strategies can be used to manage the risk of GDM and hypertensive disorders?
See, getting pregnant with the PCOS is difficult. That is just because they are anovulatory, they are having irregular cycles. But once they are pregnant, then again the first trimester, second trimester, and third trimester problems are there. In first trimester, they can have the miscarriage because of the hormonal imbalance, because they are not having enough progesterone with them. So we usually have to, support them with that hormone. In the second trimester, they can go into the preterm labor, and in the third trimester, again the same regular investigation, like doing the blood sugar monitoring, that will help us to control these patients. And just because they are the hyperandrogenism, the testosterone level is high, so they are again more prone to have the hypertensive disorders also. That again also we have to do the regular blood pressure monitoring. Lifestyle modification, again that comes a lifestyle modification, that regular exercise, or like even the walk of 30 minutes per day, or
So,
even for the
so
5 days in yes
so
week.
exercise and you can say
Yes,
exercise
and diet
and
modification.
physical
They
activity.
should avoid the complex carbohydrates.
Ma'am, how much of physical activity do you probably like nowadays? There are post getting married, and you're on OC pills because of the after getting married, and plus because of PCOS also you're on OC pills. So there's weight gain. So how much of physical activity would you usually suggest? Like I
At
mean,
least 30 minutes walk per day, at least for 5 days a week. That is
okay,
sufficient. That is
okay,
sufficient.
okay, okay. Sure, ma'am. Thank you, ma'am. Thank you for these insights. Going further to Dr. Bingi now. Ma'am, I wanted to ask you, what are the common dermatological conditions associated with GDM?
Most common we see acanthosis nigricans,
Okay,
that is, and also xanthelasma, and
okay,
diabetic dermopathy, diabetic thick skin, and urticaria also I see, and sometimes atopic dermatitis also, and the candidiasis is also very common in the patient with GDM.
okay, okay. So, ma'am, how do you usually manage them? Like, what do you do usually?
So if the patient is already has conceived or is already pregnant, then I tell the patient, as Bharti ma'am said, lifestyle modification for the canthosis nigricans. Then I start the patient on the topical therapies. If
Okay,
patient really worried about the hyperpigmentation, like then I start the patient on the skin lightening agents. If the patient has xanthelasma palpebrae, then I do the chemical cautery, which is safe in pregnancy.
okay,
Then atopic dermatitis, then I start the patient on the topical low potent steroids or the any antihistamines, which is safest in the pregnancy. And in urticaria, same.
okay, okay. Thank you, ma'am. Thank you for the inputs. Coming to Dr. Shaila Sheikh, ma'am. Ma'am, what are the benefits and considerations for long-term use of metformin in women post-delivery after gestational diabetes?
Dr. Sharima, see, metformin, we do not, I mean, a patient with gestational diabetes, by definition, is normoglycemic post-delivery. I mean,
Yes,
if
ma'am.
the patient just has gestational diabetes, I'm not talking about pre-gestational diabetes at all. Now, in this group of patients, to be able to be, I mean, there are two schools of thought. There is, of course, there's some data, emerging data, which says that you continue using metformin in these patients to prevent further diabetes, because GDM, as we all know, 50% of our patients with GDM are going to develop diabetes. It's almost like a marker for diabetes, for subsequent diabetes. But as of now, we really do not have complete evidence as to patients who are just GDM have become normoglycemic, and these patients, if you give them metformin immediately postpartum, what kind of benefit would it have long term for these patients? Because we need to understand, when we are saying you give metformin to a patient postpartum, you're also, though I agree that the secretion of metformin in breast milk is very, very minimal, and in a patient of diabetes, you can continue using metformin post delivery. But in a patient with GDM, if she's become normoglycemic, the absolute guideline regarding whether we use metformin for prevention of further diabetes during that period is still not out there. So we need to make very, very individual choices. Maybe a very obese lady whom we are worried about further progression, whom we are worried about further progression in diabetes, whom we are worried about, whether that is going to have metabolic complications for our patients, where we really want to prevent the progression of weight management, some other benefits, then we could possibly think about using it. But when we are using metformin in our breastfeeding mothers, we categorically tell them there is some secretion of metformin which is going to occur in the breast milk, though it's very, very minimal. It is considered to be safe, but this is information which should be provided to your patients.
Okay.
Along with that, when you're giving metformin long term, we need to monitor the patient. We need to monitor the patient regularly. We know between B12 deficiencies associated with metformin. So if it's a patient who's having a vegetarian diet, we need to be careful about that. And I think it's very, very important that we, at this point of time, reiterate regarding lifestyle changes. Our biggest issue postpartum, I'm sure ma'am is going to be able to talk much more about it than me. She sees patients
Yes.
postpartum. Our patients, once they deliver, Shariva, promptly drop us also. Okay, healthy baby, healthy mother, endocrinology
Actually,
no
yes,
longer required.
actually.
To be honest, I'm the last person they want to see on planet Earth once the delivery has taken place. Because mother has become normoglycemic, baat khatam. And that's where the problem starts. So actually the counseling regarding, this has to be done by Bharati ma'am more than us, because I know I'm not going to see the
Yes,
Yes,
it's
yes.
really
Most of
it's
the
really
part she
difficult to
had
take them
covered.
again on the board because once they are pregnant, they will listen you everything. Once they have delivered, then they will just disappear. So
Well
you
put,
keep
ma'am.
on asking them कि 15 days पे कराना है, 6 weeks पे कराना है, 2 months पे कराना है, but then they will just not listen you, and they will be after 2 years they'll come again with the pregnancy, and then that time she is actually frank diabetic.
Yes.
That is what happens
I
actually.
agree with you. Totally and completely agree with you. And that's the, things we face. So it's again a very, very individual decision. I would take a very individual decision, counsel the patient, counsel a family, because you just can't put somebody on metformin,
Yeah.
especially post-delivery. It's a very, very individual decision as to how you would take this forward. Yes, one of the potential therapies you can use as prevention, because we all know the DPP trial, we know it prevents progression to diabetes, is something you can think about, but take a very, very individual call.
Yes, ma'am. But then with proper counseling, with proper
Very
counseling
important.
of the patients,
In
follow-up
today's
can
world, it is
improve.
very, very important that you not only counsel, you document the counseling.
Yeah.
Document that
Recorded
has been
recorded
explained.
counseling.
Yeah, at least some documentation. I mean, I know my documentation is not the greatest on planet Earth, but at least some kind of documentation
Data.
that, okay, this has been sort of, spoken about in your consultation.
So if in case a GDM mother is there and post delivery, she takes metformin. Probably she takes metformin, and as ma'am says, regularly in 15 days does the blood glucose level and everything, or does the HbA1c or the oral glucose test, tolerance test. So if they'll end up doing that, and if required, they take metformin. Post that if the blood sugar level is high. So there are chances of the impact. What is the long-term impact of that on diabetes? Like what would you
It
say?
will definitely prevents diabetes. We all know that metformin, if you look at all the data which is available, metformin definitely prevents progression from pre-diabetes to diabetes. But if you look at the DPP data also, what it showed was that lifestyle prevents it better.
Yeah.
30% of patients in the metformin group did not progress, and almost 50% of the patient lifestyle group did not progress. But sticking to a lifestyle is not easy.
Not easy.
Because the concept, the thought process that unfortunately we all have is that I'm supposed to, lose weight, and if I've not lost weight, I'm going to stop walking. I mean, it is like, we've not been trained to think about physical health in the sense, especially as young mothers, as young adults. How much priority do we actually give to exercise? Our only conversations with, even as, if you look at parents with this, is what marks did you get? Does anybody ask you, did you walk today? Did you exercise today? It's just not something which we know, and that I think has to change before we can make a difference.
And in a nation like India, it's probably more difficult because you have festivals coming up, and then you have sweets, and then sticking to that lifestyle management becomes difficult. So probably medication pulls on a better role in that perspective on a long-term basis, basically.
I agree with you, Shariva, but the only issue is also, Shariva, that people feel that if they're on medication, they are unwell. People feel, oh my God, there's a problem.
It's all on the counseling.
It's like a double-edged
sword.
People come and ask you, मैडम अभी कितने साल तक ये चालू रखूं? आपने तो लिख दिया और बोले कि चालू रखो, लेकिन ये कब तक चालू रखूं? अरे आपका कुछ आप चल रहे कि तो वो मैं नहीं कर सकती मैम, लेकिन ये कब बंद होगी? मैं दवाई I mean, Sharifa, just taking a small thyroid tablet is an issue.
Yeah,
Oh,
yeah.
yes,
Taking a
actually,
tablet,
yes.
madam, I'm taking
Yes.
a tablet. आप
Thyroid.
समझ नहीं रहे हो.
So proper
People give the
counseling, basically.
antihypertensive, that also they are not ready to take. I always tell them, I said, एक छोटी सी गोली से अगर आपकी quality of life ठीक रहती है, तो what's the harm in taking in that? But then they are not ready to take
Yes.
that also. Not
So
ready to take that.
a long way to go as far as health is concerned. As a nation,
Yes.
we don't prioritize health.
Yes, but I think that it all depends on, probably proper counseling, as what all of y'all have said. So it's all on the clinical way you present things. So,
I
uh,
totally agree with you, Sharifa, but I think over here it's, a
yeah,
lot of social media,
yeah.
Yes.
Social media, the
wrong social media influence
YouTube,
coming.
Google
because of
Doctor,
YouTubers and all.
Google Doctor impact, the Google Doctor impact.
That's they are the biggest actually doctors.
Yeah, Google Doctor impact.
I to tell them patient I'll tell patient I say तुमने diagnosis Google से कराया ना, now go and ask the treatment also, don't come to me and whatever you have done.
Yeah. So thank you, ma'am. Thank you for the valuable insights. Coming next to the next question, going further, I would like to ask Dr. Bharti Sheth, ma'am, what are the non-pharmacological strategies like lifestyle interventions that have shown the most benefits in GDM and in reproductive dysfunction in PCOS patients? So just wanted a
It's
brief about lifestyle management thing, because young girls and pregnant ladies nowadays people are conscious for the weight gain part and all that, so wanted an uptake on that.
See, it's very simple. Diet plus exercise, that has to be modified. Diet, I always say कि ये जो junk खाते हो ना बाहर से, just stop that thing. That will be enough to lose weight actually. Whatever junk, that burger, pizza, and all those things they are eating, that has to be cut. And then again, the exercise, that is 30 minutes per day, you have to spend that much time at least for yourself. So shedding off 5 to 10% of your weight will help you out in that thing. So these are the only two things. And I always tell PCOS patients, see, there is no medicine for you to treat it, because they will just keep on hunting from this doctor to that. And उन्होंने तो मेरा PCOS ठीक कर दिया था, उन्होंने कहा, I always tell them, this is not a disease, this is a syndrome. You have to take care of your lifestyle. That is only going to, save you.
And ma'am,
Because
metformin does a wonderful role in weight loss also, right? I mean, in PCOS
yeah,
patients,
that helps them out. That
that
helps
does
them.
help. Because
Yes.
nowadays, after all the celebrities coming up and becoming Santur mothers, every woman, thinks of becoming a Santur mother. So that's the reason I asked you about the lifestyle. What kind of exercises do you suggest? Is it yoga, or is it something like, maybe nowadays there's just muscle training and resistance exercises, and people have Pilates, and there are different kind of workouts which they do. So
Yeah,
what
that
would you emphasize
see
on,
that
basically?
those are all the fancy things. I always tell them, do a simple thing, at least 30 minutes walk or 45 minutes walk, that is going to help you out.
सुबह
Rest
garden
everything,
में
you can join gym, you can go for the yoga, you can go for everything. But this is the thing where no money is involved, no efforts are involved.
सुबह सुबह उठ
That's
के वॉकिंग के लिए गार्डन में जाओ. So
that's
that's
it.
the best.
That's
That's
it.
the best.
That's the
Natural
best thing
natural
which
therapy.
one can do. Yes.
Okay. Thank you, ma'am. So coming back to Dr. Shaila Sheikh, ma'am. Ma'am, I wanted to have a word with you about this. Are there any novel therapies or any research findings that indicate new directions in the management of PCOS and GDM?
As I said, Shariva, as I said that, GLP-1 receptor agonists are very, very exciting in this area.
Yeah.
We really have some exciting data regarding GLP-1 because they improve insulin sensitivity, very good weight loss agents. So I think we're going to see and hear a lot more about their usage in patients with PCOS. What is also, some of the new data regarding inositol is also very, very promising. It's another, the derivatives myoinositol have also shown efficacy with improving insulin resistance. They help with regulating cycles. They help as far as ovulation rates are concerned. So I think these two agents are agents which are showing increasingly promising benefit. Some of the nutraceutical agents which, are also, there is some evidence regarding omega-3 fatty acids. And when you talk about newer evidence, I would think these three agents are the agents which, could possibly be used more and more in our patients with PCOS.
Okay, okay. Thank you for the insights, ma'am, because this is about the recent therapies. So this would probably bring light or new knowledge and give us better insights about the new therapies. Coming back to Dr. Bharti Sheth, ma'am. Ma'am, what are the key interventions to address GDM?
See, GDM, if we want to address that problem, actually that should start preconception, actually.
Okay, okay,
Once we know that patient is PCOS, then preconception, we should counsel them to lose weight and do the lifestyle modification. If they are conceiving with that kind of the thing that they have controlled their weight and their hormonal balance is all okay, then there are very less chances that they will land up with the GDM. But otherwise, in the first trimester, as soon as at the first visit of the patient, we have to screen them. Those
okay.
who are obese and having GDM history or that kind of family history of diabetes, they should be
Oh,
screened at the first visit only. Like whenever there is first antenatal visit is there, we need to do that blood sugar fasting and then that 75 grams OGTT test that has to be done. If they are identified there only GDM, then it's fine. We will keep on doing the routine screen this investigations for them. But suppose she's not having GDM at that point of time, then again we have to do the test at around 24 to 28 weeks in the second trimester. Again the same test is done, OGTT is to be done. If they are GDM, has to be managed accordingly. Second thing, with the this thing diet modification, like we need to tell them that they have to be low on the carbs and high on the proteins.
okay.
And then lifestyle modification, again that comes exercise wala part. But if they have developed the GDM, then we nowadays we are actually starting with the metformin as a first line of treatment. For me, at least, I am starting in that
Metformin.
metformin as a, because earlier we were only relying upon the insulin, but insulin being the injectable thing, and then the incidence of hypoglycemias are more with the insulin. That is slightly, regulating that kind of thing is मतलब मुश्किल हो जाता है पेशेंट के लिए ना अपने आप से करना. But metformin being the oral medication, and then the chances of hypoglycemia are less. All those, and then it's not very costly also. So that cost
Okay.
effectiveness is also there. So for me, at least, I am starting with the metformin, and then we have to do the regular blood sugar monitoring, how we can adjust the doses and all. So
So,
that.
ma'am, metformin being an oral medication, ma'am, so does it will have a better impact you feel as compared to insulin for the on the patient psychological factor?
Yes, actually, patient, because taking injections, that is slightly, patients, they are apprehensive taking the injectables.
Yes.
Oral medication, that is more acceptable to the patients, actually.
So metformin is very effective in GDM, and it is
Yes,
the
I have seen in my practice, I have seen the metformin is quite effective. It's
so
quite
it
effective.
keeps the mother healthy and the baby healthy. So it's mother baby
Yes,
healthy
yes.
concept which is there.
If we can keep the blood sugar levels in, range, then it's really helpful.
Okay.
But sometimes we really have to add the insulin in the later phase, like in third trimester, you may have to add on the insulin for some of the patients, but usually metformin works.
Okay. Okay.
Yeah.
Thank you, ma'am. So, coming next to Dr. Shaila Sheikh, ma'am, how does PCOS and GDM impact mental health? And what role do endocrinologists, gynecologists, and dermatologists play in addressing the psychological aspect of the condition?
Both PCOS and GDM influence mental health to a very significant extent. For example, we've already said that, Dr. Bini also said, Dr. Bharti also spoke about the issues where where the patients are going to have body image issues. There can be body shaming
Body
involved.
shaming.
Yeah, there can be significant amount of body shaming involved. We have patients being called, because of the hirsutism, being called all kinds of derogatory names. There can, for example, recently there was, this year only, there was this image of this child who came first in the exams, and the picture was not commented about the exams, but there was a lot of trolling because of the hirsutism, which is very, very sad, which is very, very sad. It became a viral post practically. So we do face patients, I mean, but a lot of patients do not really talk about it. Some patients tend to internalize it. It requires a lot of, because a lot of patients do not sometimes, or sometimes patients do not realize that we are actually on the same side of the table as them. They perceive you on the opposite side of the table. And recently, for example, when we are talking to a child who was dealing with obesity and PCOS at the same time, when we just told her that we understand you're doing whatever has to be done and it's not working out for you, she was almost crying for 10 minutes because she's saying, this is the first time somebody told me that, okay, I'm doing something. Otherwise, every time I'm just being told that I'm not doing enough. I'm not doing enough. I mean, when I'm doing whatever I am capable of. So I think mental disturbances, mental health is a very, very important parameter that needs to be handled very, very sensitively. I would suggest, I mean, a team does help as far as handling mental health is concerned. This becomes very, very important when you are handling your patients, because they can, and I think family support makes a very, very big difference. I personally feel it's very important that you take the family into confidence, be it a mother, be it a spouse, be it a friend, be it whichever family member. But you as a clinician may not be able to walk the entire road with the
Yeah.
patient. So unless you have maybe a friend, maybe a colleague, maybe somebody from the workplace, because with mood disorders, sometimes the workplace can be a stressful environment. If you can explain to a family and help and tell them that this person needs support.
Support.
If you go online, you have these huge number of PCOS support groups, which, you're like, okay, why do you need so many support groups? But I have patients coming to say, ma'am, I belong to, I recently had a patient who was belonging to 5 support groups. She's saying, okay, I need different kinds of. So, then patients feel that they are not being looked after by us as clinicians. That's what they tend to then, go towards. So, I think it's very important that we recognize, we understand, we sensitize ourselves and society, and we empathize with our patients. Because unless we empathize with our patients and tell them, okay, it's okay, we know you're trying hard, we know this is a tough road, we know it's not working out the way you want it to work out for yourself, and we are there for you, unless you have these messages going across, it just simply is not going to work out the way you want it to work out.
I'll add on
Basically,
one line
yeah,
over here.
yeah.
Sorry, interrupting. They are the patient. Actually, they need that TLC, tender loving care. Actually, we clinician can be of big support to them, because पेशेंट को क्या होता है, उसको लगता है पीसीओएस है, लाइफ लॉन्ग आई विल बी पीसीओएस, आई विल हैव दिस प्रॉब्लम. सो वी रियली नीड देम टू अंडरस्टैंड, सी दिस इज नथिंग, मतलब आपको ज्यादा परेशान होने की जरूरत है, जस्ट सिंपल लाइफस्टाइल मॉडिफिकेशन विल हेल्प यू आउट. एंड दिस इज नॉट अ डिजीज विच वेयर, मतलब तुम्हें कुछ प्रॉब्लम होने वाली नहीं है, इफ यू विल अबाइड बाय द वर्ड्स ऑफ द क्लिनिशियन. सो दे रियली नीड दैट काइंड ऑफ टीएलसी.
Basically, it's all about the mental support given to the patient
Yes,
and the
that they
family of
really
the
did, because
patient. Like,
yes,
so
yes.
because that plays a very important role, as they are 24 hours with the patient. So that is a very important factor. Okay. So coming lastly to my last question. This question I would like to ask Dr. Bini ma'am. So ma'am, what is the psychological support and intervention can a dermatologist offer to patients with PCOS to help them manage the emotional impact of skin conditions, improve body image, and reduce stress?
I think Bharti ma'am and already explained very well. First, because due to the chronic nature of this disorder, it increase the risk of the development, psychological and the behavior changes. And it has been reported 50 to 60% of the women with PCOD at least have one mental disorder. So appropriate counseling should be offered to every PCOD patient, CS patient, and also to the family member, because because PCOS patient, because it jeopardizes the feminine effect identity of a woman, like because of the hirsutism, because of the obesity, because of the androgenetic alopecia. So appropriate counseling should be a routine part while evaluating the patients. So to counsel the patient, like same as Bharti said, lifestyle modification, even small changes in the diet can, in a low fat diet, low junk food, it can also improve the important features of the PCOS. And another, I also tell the patient, do at least walk 30 minutes, and Rati ma'am said that 30 minutes in a day. So it will release your feel good hormones, which automatically decreases your stress level, and also improving the reducing the weight, also improving your hormones, and also improving the important and then that is features of the PCOD. So automatically PCOD will correct automatically by these small changes like lifestyle modification, like walking for 30 minutes, because the age of the PCOD is now has been literally very decrease in like school going जो होते हैं students they no हम सारा दिन पढ़ते रहते हैं, we don't have time
Yes,
to work.
actually.
Then I tell the patient, अरे बायो तो ऐसे ही पढ़ी जाती है, पर चल चल के पढ़ो, बायोलॉजी तो ऐसे ही पढ़ी जाती है. तो ऐसे I tell the patient कि मतलब that is the important line of treatment, as Bharti ma'am already explained very well, कि ऐसे मतलब small changes in the lifestyle can improve the important features of the PCOS.
Like, ma'am, for example, like the youth of the nation, like young girls who come, they have these body shaming issues of weight, of acne, or probably, all these excessive hair, hirsutism, like all these issues, because of which sometimes they can't, they feel ashamed to go out with their
They
friends, or
don't
they don't can't go for occasions or
they don't go to social
so
gathering and
yeah,
party
so
and
that
all.
mentally takes a toll on their mental health. So, ma'am, what is your outlook on this point of view? Like,
Then
what
I
should
tell
they
the
do in that
patient,
scenario?
whatever the unwanted hair growth, I will take care. That is my part of the treatment. Acne, I will take care. Androgenetic alopecia, I will take care. From that, you don't worry about that. But from your point, from your side, you have to take care of these things.
Wait, yes.
Okay,
Actually,
okay.
actually.
Okay? So together we can treat the PCOS. I tell the patient. थोड़ी सी
Okay.
कोशिश आप करो, थोड़ी हम करते हैं.
थोड़ी
So
सी
it's
हम करेंगे. Yes, very
it's a
right you are. That is what
it,
I always tell my patients.
थोड़ी
कुछ
सी
तुम करो,
कोशिश
कुछ
आप कर
मैं
लो, थोड़ी
करूंगी
हम
तो
कर
मिलके हो
लेंगे,
जाएगा.
मिलके हो जाएगा.
it's a teamwork. It's a
It's a
teamwork.
teamwork.
It's a
Yes.
teamwork.
So,
Yes.
So
ma'am,
it's a teamwork of the gynecologist,
Because
endocrinologist.
only medicines just don't help. Only
yeah,
medicines just
yeah.
don't help.
So yes, that is
They
the
need that personal connect and that
yes,
Yes,
that
very very
yes.
tender
Actually.
touch they want.
that
हाँ.
personal connect and that warmth
And
and
one more thing, I tell them, I said, don't Google the things.
yeah.
Google pe mat padna, you will go mad.
Yes,
You
yes.
whatever question you are having, you ask me. I am always there to answer your questions. But please don't Google the things because PCOS को मैं ही नहीं पढ़ समझ पाई आज तक. तुम्हें क्या समझ आएगा Google पे? That is what I tell them.
Yes, ma'am. Yes,
So
ma'am.
that is थोड़ी सी teamwork है, so we can improve the things. We
It's
can treat
good.
things very well.
It's good to know that that we are there for the patients and we are for the patients 24/7 throughout as a
So it
team.
is very important कि हाँ कि जैसे मैम ने बोला कि family members को भी
Yeah,
counseling की बहुत जरूरत है, because they
caregiver.
most of the mother said नहीं हमारे टाइम पे तो एक्ने आते थे, हम तो ऐसे ही कर लेते. But what is the mental status of the baby and the child or
Yeah,
whatever
yeah,
female?
yeah.
They should also learn how to tackle the things
Yes,
if the
yes.
patient. Yeah.
So basically, it's right counseling and the
Yes,
teamwork and the
counseling
family
is
work.
the corner line of treatment. First is the counseling, then we should proceed for the treatment.
Okay, okay. So, ma'am, there are few questions from the audience which have come up for all of y'all. So I'll present one each question, and maybe you all can answer it through your point of view. So, ma'am, people want to know what's the role of metformin in PCOS, and in GDM, should metformin be continued throughout the pregnancy, like pertaining to each trimester, first trimester, second trimester, and third trimester, or postpartum, basically? So these are the questions, and there are few more questions also. So we'll go question wise. So there are these two questions first.
See, metformin has to be given. If you're a GDM, then you have to take it because otherwise you'll become a frank diabetic. and that is a very problematic thing. So it has to be continued first, second, third trimester. It's of no harm actually. It's a very safe medicine. In the postpartum, again, we really have to regularly monitor the blood sugar, like at 15 days, then 6 weeks, and then 6 months, and then 1 year and 2 year. That strict follow up is really needed. And if sugar is on higher side, then we can always continue with the metformin.
Okay, okay. So, ma'am, what is the recommended dosing protocol for metformin and GDM? And are there any particular considerations based on the patient response?
Yeah. It all depends what are the sugar levels of the patient, because we need to keep the blood sugar fasting levels between 95 to 100. Till
Okay,
100 that should be there, and that should be postpartum is 140. So we have to tailor made the doses according to, because the blood sugar monitoring every day has to be done fasting, and then post lunch and post dinner. So whatever those values are there, according to that we are going. We may start with only 500 milligram once a day, but then we may have to make it 3 times a day, because then blood sugar values dictate the doses of the
okay,
medicine.
okay. So, ma'am, coming to the next question, what are the potential long-term outcomes for children born to mothers treated with metformin versus insulin?
So as of now, there are no differences there. Nothing. In fact, those who are diabetic, that they're whose blood sugar is not controlled, they are having the problems. But those blood sugar is controlled with the metformin and insulin, they are doing well. But yes, all the PCOS mothers and GDM mothers, their kids actually they are prone to have the type 2 diabetes mellitus.
Okay,
That is a genetic factor which is
okay,
coming there. That is
okay.
not because of the medicine. That is a genetic
Genetic factor.
element which is coming there.
Okay, so ma'am, how effective is metformin in managing blood glucose levels in patients with GDM compared to insulin?
So it's equally effective. That is what I told you, na, ki if
But you
blood
have
sugar
not
levels
seen
are okay.
any side effects in the babies or anything like that,
No,
like no side effects,
no,
nothing,
nothing is there.
nothing like.
As of now,
Yes,
studies are not says ki nothing is there.
because recently it's been approved now by DCGI and
Yes.
it's been approved. So
Earlier, we
that's
were
yeah.
having the insulin as a first line treatment, but now for almost of 5-6 years, we are using the metformin, and it is doing well.
So potential, ma'am, someone's asked a question. What are the potential long-term outcomes for children born to mothers treated with metformin versus insulin? So they wanted to know about the outcomes of the
No,
children.
actually, metformin itself leads to the vitamin B12 deficiency in the mother, actually. So that can be of some concern, but otherwise, no other side effect is there.
Okay, okay. So this is last question which is there. They are asking how to treat milia.
What?
How to treat milia. So
Milia?
yeah, milia.
What milia? What is that?
Milia,
I'm
Anemia
not
is,
getting it.
milia,
is it,
dermatological condition, I
That
I
think.
is
think
the
it is not related to PCOS. Just
Yeah,
random question.
someone has asked this question, how to treat milia. So
So milia is it because of the clogged sebaceous gland, है ना?
yes,
So it won't
probably.
go, it will not go with any topical medicine and with oral medicine. We have to extract, like removal only with needles or with the medial extraction we have to do.
Okay, okay.
So
Fine. Sure, ma'am. So, ma'am, thank you for all of y'all for your valuable inputs, for your cutting out time for us, coming on this podium, probably guiding a lot of people, and for your presence out here. It made a lot of difference. Rather, it will make a lot of difference because these kind of interactions, these crosstalks, it is more interesting. It probably helps in solving more doubts, and it helps us in educating people, at the same time educating us also, and getting better insights about the medications in the market. So thank you for your presence, thank you for the time, and it is a privilege to have you on this podium with us. So would you all want to say something before we probably end the program, or
Even I enjoyed the program because I get to know certain new things from the dermat and the endocrinologist. Thank you very much for organizing this kind
yes,
of
yes,
webinar.
Bharti
So
ma'am
even we are
has
benefited.
explained.
Even we are benefited.
Bharti
okay.
ma'am explained everything very well. So मेरा part
Thank
वो
you.
कम हो गया था बोलने वाला कि automatically
It's
कम हो
okay.
गया था
No,
कि
because
मैंने
this is all joint action होता है ना हमारा सबका
हाँ,
इसमें. So we know about you know about my treatment. So
yes,
it's all
yes,
So
yes.
I would want to
was
even
very
thank
informative.
all the delegates, all the audience and team USV for collaborating and coordinating really well with all of us, and the audience and the delegates for getting time out on Saturday evening for all of us here. Thank you for your presence, and at the same time, thank you to the tech team for wonderful collaboration. And thank you for giving me a chance to host this
Thanks
knowledgeable
to
event.
you for conducting the session
Yeah,
so
yeah, thank you.
nicely.
It is
Thanks.
it
Thanks
was
to
very
you.
informative. Yeah,
Yes.
Thank you, ma'am. Thank you.
thank you.
It was
Thank
my
you.
pleasure. Yeah.
Thank you.
Thanks.
Thank you.
Thanks, Team
Thank you.
USP, for
Thank you.
giving us this opportunity.
Yeah.
Thank you.
Thank you.
Thank you so much.
Yeah.
Okay.
As we
Okay.
come to the end of this program, definitely I'll be taking like 5 more minutes, like quickly go through the USV
Okay.
corporate presentation. But ma'am, as I said, it is going to be a great evening for each one of them, like who's going to present and attending this today's crosstalk session. And thank you so much for making like that. So, ma'am, yes, your reliable healthcare partner, USV is always there. Young, 62 years, young USV, young in healthcare. Now, there are a few things to talk about that one out of every fifth prescription in diabetes contains USV OAD brand. Now, they are leaders in the cardiology by prescriptions. Now, leaders in diabetes, oral and value on prescriptions. Global leaders in metformin. One out of every six tablets sold in the world is supplied by USV. They have a presence in 66 countries. Now, we talk about the profound gratitude. So, definitely, our aim to partner is to ensure better patient care so that India can be recognized as a metabolic care capital rather than a metabolic capital of the world. So that is what USV is looking for. Our roots are deeply ingrained in our Indian history. So a founder of USV is Dr. Vittal Balakrishna Gandhi, and which is then successor taken by Arvind Vittal Gandhi, and now current leadership is there Mrs. Leena Gandhi Tiwari and Mr. Prashant Tiwari. Now you can see there are two streets in Mumbai's business locality are named after our founders. Now Jawaharlal Nehru and Vittal Gandhi in discussion with the Japanese delegation in India. Next, the backbone of our business definitely world-class manufacturing campuses, active pharmaceutical ingredients, which is their API in Chiploon and API Ambernath. Nerul plant is also there with us, biologic manufacturing factory, Baddi HP finished dosage formulation, and in Daman finished dosage formulation also we have. So when we talk about dedicated plant from a glycobit GP is Vadodara. EcoSprint AV is the biggest brand that we have that is in Baddi, Himachal Pradesh. And sustainable responsible manufacturing, when we talk about, it is untouched by hand. The solar power usage of 600, zero liquid discharge, rainwater harvesting is there, paperless manufacturing lab, green belts, 800 trees and 3111 square meter area is there where we are maintaining that sustainability. So when we talk about 1/6 of the world requirement of metformin is supplied, so quality of USV metformin is highest that we proudly say because it is FDA as per specification. NDMA we are maintaining. You can see that for a glycomet SR 1000 for 850 and 500 NDMA level is in definitely control as per the guidelines. Well, thank you so much for all the support that we have a brands, EcoSprint range that we have Glynaze, Triglynaze that we have for a deserving class of patients. We have a Vibact also. We have a Eritop from the dermatology, the derma ends. And then we have a glycomet range, glycomet GP, glycomet Trio. We have a Insu Quick, that is the insulin that we have with us, Liranin DP, that is a linagliptin and dapagliflozin. We have a Jalra, that is vildagliptin range, Udapa range that we have, which is a dapagliflozin, Rose Day range that we have with us, which is rosuvastatin, and Tazloc whole range that we have with, which is the telmisartan range. Going ahead, we believe knowing is not enough and we must apply. Wishing is not enough and we must do. If you want to see the change, be the change. This is what we believe. So when we talk about, we are aware of the challenges in disease awareness, screening and diagnosis, education and research, infrastructure, capacity building. So life without a purpose is meaningless, and we have a purpose which is beyond business to be part of you, your and your patient journey that we are always there with you. Going ahead. So disease awareness, we have been doing it from last 10 years in the TV and radio and Facebook and Insta and definitely the print media that we are doing because metabolic care capital of the world, that is what we are partnering with more than 6 decades with the doctors. So screening, when we talk about, we are more than 5 decades for hypertension, dyslipidemia, complication, diabetes, obesity. So we are doing this screening things, screening and diagnosis. Next, please. Yeah, encouraging research here more than year to, 2000. So we have got a ESI AV Gandhi Award for Excellence in Endocrinology, AV Gandhi CAI Award for Excellence in Cardiology. We have ESI AV Gandhi Award for Excellence in PhD Endocrinology. India Diabetes Prevention Program was supported by USV. And as I said, our partnership is with SCP is more than 6 decades. Continuous medical education collaboration that we are doing with the different bodies that like Association of Physicians of India, SCAI, RSSDI, Indian Society of Hypertension, and ESI, which is the Endocrine Society of India. Our partnership with SCP is more than 6 decades. So when we talk about infrastructure capacity building, ECG learning courses for our paramedicals that we have, beta course, Save a Life, an initiative to educate people on symptoms of heart attack, and training of more than 1 lakh people, including paramedics, on how to resuscitate in emergency situation like sudden cardiac arrest. And also we have a national diabetes educator program entering in 14th year now, created more than 22,000 diabetic educators till now. So India Insulin Education Program, that is the India Insulin Education Program. We have a MyCare, a 20-week patient support program for people with diabetes and insulin. TIDE, we can talk about the design to impact the deep and structured education on type 1 diabetes. Created 389 T1D educators in 2023-24. NIEP that we have certification course for nurses on diabetes management with a special focus on insulin, which is accredited by TNAI also. CIEP that we have to impart practical knowledge on the cold chain product storage delivery to improve patient outcomes. Insulinization for India to educate physician on insulin initiation and intensification for early and right uses of insulin. GDM courses, a certification course for physicians and gynae that we have been looking at. Next, please. Yeah, when we talk about sustainability, definitely we want to do something for today so that our future generation will thank us. So solar energy uses 1220 kilovolt amperes, carbon dioxide emission reduced by 4,000 tons per year. So when we talk about green insulin, recycled plastic waste created by our insulin pens, and this one TR bottles to make our product plastic neutral, and to create awareness on right disposal of sharps and insulin needles. This is what we are doing. So thank you so much. Thank you so much for your 5 minutes of patient hearing. Definitely. Now coming to the end, we express our heartfelt gratitude to whom all that made Crosstalk PCOS and GDM management possible. First and foremost, I extend my deepest thanks our esteemed speakers. We have a Bharti ma'am, Bini ma'am, and definitely Shaila Sheikh ma'am there with us. Thank you, ma'am, sharing your expertise, insights, and valuable experience with us. Definitely, your contribution will definitely, and truly enriching and offering both a scientific and practical perspective on managing PCOS and GDM. To our audience, thank you so much for your active participation, and there are so many questions that you have been asking. So your engagement made today's discussion definitely vibrant and productive. So we are delighted to see the community shared interest in understanding managing PCOS better and GDM better. We also extend our gratitude to everyone behind the scene, the organizers, the technicians. Thank you, Dr. Shariva, and support staff for their hard work for bringing these events very seamlessly, and it is successful. Finally, let's keep the conversation going beyond today's session, as together we can continue to promote awareness, education, and support around PCOS and GDM, which is very much important, empowering individuals to lead healthier lives. So thank you once again, and we look forward for many more such impactful sessions in the future. So wishing you a wonderful day ahead. Thank you so much. Thank you, Bharti ma'am. Thank you, Bini ma'am. Thank you so much. Thank you, everyone. Thank you, Dr. Shariva. Thank you all.
Thank you. Thank you.
Thank you.
Thank you so much. Good night.